Hi, everyone. My name is Josh Bauml. I am a medical oncologist at the University of Pennsylvania. And I am so pleased to welcome you to the Cancer Grace ASCO ESMO update. So this is great. And I have some fantastic friends and colleagues here to talk about all the updates from head and neck cancer at these big conferences. So joining me today are Dr. Kathryn Gold, from the University of California, San Diego, Dr. Ranee Mehra from the University of Maryland, and Dr. Jared Weiss from the University of North Carolina. So we have discussed on other video podcasts, I'm not sure what the technical word for this is. Anyway, so we've discussed on many different trials, positive, negative. I wanted to ask each of you, when you look towards the future, what are you most excited about in the field of head and neck cancer? And so I'll go first to Dr. Weiss.
I wasn't muted. I was muted. I wasn't ready for that. So I think there are multiple avenues that are really exciting. One that I would highlight is more personalized immunotherapy approaches. So in the past, when we've talked about precision medicine, it's meant using some biomarker to match the right off-the-shelf drug to the right patient. And I still think that there's a lot of promise for that in head and neck cancer and other cancers. But in parallel with that, I think that there are more personalized immunotherapy approaches that might be really exciting. So in the context of HPV-driven disease, there are some of what we call preserved neoantigens, which means ways that the cancer cell looks foreign to the immune system that are necessarily there, that pretty much every HPV positive cancer is going to have. And I think there are already some exciting efforts, one of which I'm sure you're familiar with therapeutic vaccination, that are showing us the promise of this approach. And I would highlight both vaccination and cellular therapeutics approaches in this space. And then in the realm of HPV negative, there's emerging technologies to either use something called TILs, which are where you resect a piece of cancer and you take out the immune cells that are there, with the idea that if they're there, they're probably there because they're attacking cancer. You amplify them and you give it back as essentially like a drug product. There's a bit more to it than that, but for speculation, that might be enough for here. And there are exciting technological advances to making personalized vaccines and cellular therapeutics products against the HPV negative cancers that I think over maybe the 5+ year time horizon might have us curing more of the incurable patients than we are now.
Great. Dr. Gold?
Yeah, so despite the negative trials that we've had presented this year of combining immunotherapy with radiation, I still think there's going to be a role eventually for immunotherapy in locally advanced disease. It's how most of our patients come in. Our treatment is not great right now. We need to make it better. So I still think there's a role there. Completely agree with Dr. Weiss. We have to personalize these therapies. We have to figure out, who's going to benefit from them, who we're just going to give side effects to without necessarily a possibility of benefit. And I think that's a really promising area. I agree with you on the therapeutic vaccines. I think there's some really cool work going on right now in both off-the-shelf and very personalized vaccines that will hopefully revolutionize our care in the next few years. And I do want to say that I don't think targeted therapies are dead. We've seen some data this year with apoptosis-targeted proteins. In other types of tumors, there have been advances as well. So even though we're all about immunotherapy right now, I still think there's a role for finding good targets for patients. We haven't been great at that for squamous cell carcinoma so far, but I think there's a lot of room for improvement. And I do think there's some ongoing stuff that's pretty cool.
Great. Dr. Mira?
Well, I think, there certainly are a lot of exciting avenues that people are studying. I think just to even take a step back, what's exciting to me as a medical oncologist that, the role of the medical oncologist in the multidisciplinary care of head and neck patients is shifting. And it wasn't that long ago that, we were kind of the last members of the team and sort of the poor country cousins that, the patients would have to meet if they needed platinum every now and then. And I think we really have evolved as a field beyond just the individuals who give people cisplatin. And I think that gives a lot of potential for future study. There's been a lot of interest in neoadjuvant treatment approaches. And so, you know, to have us be the first intervention is kind of mind-blowing, right, for this disease. And we still don't know the full impact of that, but I think there's a lot of really interesting clinical trials happening in that space, which could potentially change practice, but could also teach us a lot about the biology of the disease if we give a systemic therapy first and then do a resection. And so this is really, truly a collaboration with our surgical colleagues, which I think could give us a lot of interesting things to talk about, you know, hopefully in the near future. I agree, cellular therapies are intriguing for solid tumors in general, and there have been some interesting programs developing in head and neck cancer. And, you know, with HPV-related disease, there are even some programs which are looking at more engineered products. But even in the absence of that, the TILs or tumor-infiltrating lymphocytes are an area to watch for. And I agree also, you know, we still have a lot to learn about how to incorporate targeted therapies and using biomarker selection for our patients in that regard and with immunotherapy.
Fantastic. Well, there's certainly a lot to look forward to as we advance the field in head and neck cancer. So I wanted to thank you all for joining us today.
Wait, Josh, you don't get out of giving an answer to this.
I do. Sorry, we're out of time. It's no, I think the comments you made are wonderful. I think that, you know, cellular therapies, advancing immunotherapy, targeted therapy. I would add that, you know, I think that as we discussed in one of the other videos, biomarkers are really critical in terms of guiding the use of these drugs. This is not going to be a one-size-fits-all approach, but I think that the future is bright. I think that there's a lot of work to be done, and I think we've seen advances and we will see more as we move forward.
Two other things to just really briefly mention that I think are of promise. The first is probably worthy of its own hour-long video, if not longer, but to just briefly mention that there are a lot of exciting attempts to decrease the intensity of therapy for our HPV-driven patients. We know their prognosis is better. We've had multiple positive studies looking at how to leverage that to make the treatment less brutal. And I think we're going to see much more data on just how low we can go, just how gentle can we make this therapy without harming cure rates. And as a related item, we've had some advances in monitoring. We have now an approved product for using circulating tumor DNA to monitor disease, maybe some work to define its optimal use. But the operating characteristics, meaning how well it works, seem to be great. And we have a lot of studies ongoing using blood, urine, saliva, a lot of different ideas, but looking for HPV DNA to screen for disease. And I think there's no business that would love to be put out of business more than the oncologist. Wonderful as all of our therapeutic advances are, I would greatly look forward to having fewer patients, to having screening pick them up at stage 1 or even pre-stage 1.
Yep, absolutely. It would be, I'm very happy when there are not, I would be very happy when there are no more patients with cancer. That would be fantastic.